all the different kinds of shock is a pretty important topic that you'll have to be very not only comfortable at catching, but also knowing when someone is in a certain type of shock. And one of the key things that we talked about last time that really plays a big role with that is the calculation of PCWP. So we went back to the step 1 book to look at how PCWP was calculated and how you put the catheter into the Swan-Ganz catheter into the heart to actually occlude the pulmonary vessels and measure pressure inside the left atrium. So we have hypovolemic, cardiogenic, obstructive, and distributive shock. And then there's all these images from UWorld. And then coming back here, I have a pretty good thing here too. So let me pull that up. There we go. Okay. So hypovolemic, cardiogenic, obstructive, and distributive. So let's take a look at it in the CK book first. So cardiogenic shock. Cardiogenic, as you can tell from the name, it's generating in the heart. So it's due to the heart itself, due to some kind of MI, heart failure, valvular dysfunctions like usually mitral aortic stenosis, arrhythmias, and other conditions intrinsic to the heart impairing left heart function. Right, so primary disturbance. This is why these images are pretty nice, so you can see where in the loop the actual problem is in this patient. So it's in the left heart, right? Something isn't working in the left heart, so you have, because the left heart's contractile function is no longer working well, for one of these various reasons, you have a very, very low cardiac output. This leads to an increase in systemic venous return, right? So let me see where the equation, yeah, so this equation up here, right? Cardiac output times systemic venous return is equal to mean arterial pressure. So if you lower your cardiac output, if the cardiac output goes down, then you want to make this a bigger number to be able to maintain the same mean arterial pressure, right? Just like how 4 times 4 is 16, but then if you want to do, if your cardiac output becomes 2, so let me put that like 4 times 4 is equal to 16, right? So now if your cardiac output gets halved to 2, then you need to double this to 8 so that you would still have the 2 times 8 is equal to 16, right? So to maintain that mean arterial pressure, the 16, you have to have a balance between the cardiac output and your systemic venous return. So that's what's happening here, right? Your SVR goes up because your cardiac output went down. The primary disturbance is a significant reduction in cardiac output. So to balance this out, our body will increase SVR as a reflex to maintain mean arterial pressure because of this critical equation from cardiac physiology. Since cardiac output is impaired, blood will back from the left atrium to the lungs, so PCWP will be elevated. Right, so because this isn't working, blood will start backing up into the lungs. Okay, this is remember that blood was supposed to come into here, into the left atrium from the lungs, but now it's not going to be able to. Pretty much the same symptoms you have in heart failure as we talked about last time. Blood won't be able to come from using all the pulmonary veins to come into the left atrium, right? So now all that blood is going to back up into the lungs. That leads to problems in the pulmonary arteries all the way back here, and central venous pressure will also be elevated. So basically everything backs up. Right, so the critical things you note in cardiogenic shock, your central venous pressure is going to be high, PCWP is going to be high because your left atrium is unable to contract correctly, so a lot of pressure is building up there. Your cardiac index is going to be low. Cardiac index is pretty much synonymous to saying left ventricular output. Right, so if you were ever confused when you saw that in a question and they told you the cardiac index, just think of left ventricular output, and it's also pretty synonymous to stroke volume in a sense. So cardiogenic shock, you're going to have a decreased cardiac index, and then SVR, your afterload, your blood pressure generally speaking, systemic venous resistance is going to increase in cardiogenic shock, right? So this is all going to end up making great sense to anyone who can then, once you analyze this image, anyone who presents in the clinic with any of these symptoms, any of these conditions, this is what you decide to pick as an answer choice. Now, most questions about cardiogenic shock that I've seen in CK haven't really been where you just pick cardiogenic shock as an answer choice. They'll give you parameters like these, and then you'll have a bunch of up and down arrows, and you have to pick something. And oftentimes, there's always that one random thing that isn't from here, right? For example, you could have a question about a patient who has heart failure, and the question is definitely at that point going to be about cardiogenic shock. And then on your up and down arrows, one of the parameters might be something like BNP, which you would expect to be up, right? So something like that can happen. And just be very careful in understanding that. And then of course, since this is all related to the lungs, which is basically what you have right here, right? The lungs are supposed to be the ones sending the blood to here, right? Same thing here as well. You basically have your lungs on both sides of this thing in a sense. That's what completes the circle. So since this is also related to the lungs, another parameter that you can have in your questions about the up and down arrows is hypoxia related stuff, right? There will be difficulty in doing gas exchange in these people because there's going to be too much fluid within the lungs. Coming back to step 1, same thing, right? So here you see all the same stuff. They have questions where they often mention cold and clammy, right, upon physical exam of the skin. And for treatment, you're going to see that throughout FACK in more detail. But generally speaking, you want to start giving them something that helps their heart beat better. And then you want to get something like furosemide to help them offload that extra fluid that they're accumulating. Next thing here is your obstructive. So obstructive gets broken down more in first ACK, right? In step 1, it was just called obstructive, and then they listed everything, and they pretty much paired it with cardiogenic shock, right? Because cardiogenic and obstructive are pretty much from the same branch of things. The only difference is cardiogenic means it's intrinsic to the heart. Obstructive shock means something outside the heart is messing things up, right? So now in CK, you learn that obstructive is further broken down to post-pulmonary versus pre-pulmonary. Right, and those are the two images you have here, and you can see how the clear difference is that, you know, in primary disturbance in this one up here, where it's post-pulmonary, the issue is on the left heart, and in the pre-pulmonary, the issue is on the right heart. So let me pick each one by one and just make the image bigger. So let's look at post-pulmonary first, right? So post-pulmonary is this image right here. So I wrote here, if it's post-pulmonary, so obstructive means that some problem is outside the heart, is impeding good function of the heart, generally speaking. So if it's post-pulmonary, then the primary disturbance is reduced cardiac output due to impaired left ventricular outflow. Maybe the patient has aortic dissection or severe aortic stenosis, anything that's leading to the same presentation as cardiogenic shock with elevated central venous pressure and PCWP. Generally speaking, you're going to see the same things in that version of it, right? So you see obstructive shock here. This has an asterisk on it because the asterisk says in tamponade, left-sided preload is decreased, but measured PCWP is paradoxically increased due to external compression by pericardial fluid. So generally speaking, for obstructive shock, the PCWP really will depend on what's causing the obstruction, right? Whatever's causing the obstruction to occur, that's what's going to decide what the PCWP is going to be like. But for obstructive shock, central venous pressure will be up, same reason as cardiogenic shock, because the heart's not beating correctly. Cardiac index will be low, same reason as cardiogenic shock, because your left ventricular outflow is decreased. And then systemic venous resistance will be elevated in both cardiogenic and obstructive shock for, again, the same reason as cardiogenic shock, because you have a lower stroke volume, right? So if your cardiac output goes down, you have to increase your systemic venous resistance, which is basically your blood pressure in a sense. The other one, so let me make the other image bigger now. Your pre-pulmonary one, this one is where the problem is in the right heart. So you see the primary disturbance is impeded cardiopulmonary blood flow, such as a pulmonary embolism or a tension pneumothorax, right? They gave examples in this one too. Here they said that it could be impaired left ventricular outflow due to aortic dissection or severe aortic stenosis, any one of those two case scenarios. So let's look at this one now, pre-pulmonary. So in pre-pulmonary, the primary disturbance is increased central venous pressure due to something like cardiac tamponade. And we spoke a little bit about cardiac tamponade yesterday. I'll talk about what I said one more time to make the point clearer with the image here. But cardiac tamponade, pulmonary embolism, tension pneumothorax, and any other condition extrinsic to the heart that will then impair right heart function. Remember that your right heart's function is to send blood into the lung, right? It's receiving blood from all the different venules of your body, inferior and superior vena cava, and all the blood is coming into here deoxygenated. And then the right heart's job is to send it into the lung to get it reoxygenated again. So if something is wrong with the lungs, right, and then you can once again see the direct connection again. This is pre-pulmonary now. Pre-pulmonary in the sense that is before your pulmonary veins can bring blood to the heart. That's what this pulmonary is referring to. So any one of these things that would then impair right heart function. So now blood cannot be pumped into the lungs or the left heart, thereby reducing PCWP and cardiac output. Right here, PCWP will be low because there's no pressure in the left heart at all, since not much blood is going to make it. Right? So this case scenario is a little different from the other two. Anytime cardiac output decreases, there will be a reflex increase in systemic venous resistance. Right? So PCWP in the middle here is decreased for prepulmonary obstructive shock. Right? But here, again, PCWP really depends on what's actually causing the obstruction. So if I was to use, let me see if I can, not this picture. We'll just use this one then, since it overlaps everyone else. Okay. So in cardiac tamponade, right, what happens is that we have this bag of fluid around the heart outside, right? And it's basically going to be a sense of restriction on the heart, so that when the heart is filling up, it's unable to expand. So now when you do inspiration in any individual, you bring more blood into the right heart. So when this person with cardiac tamponade does inspiration, more blood comes into the right heart. The right ventricle cannot really expand outwards because of all this extra fluid outside. So instead of doing that, what happens is it's actually going to push this interventricular septum into here. Right? It's going to push this in this direction to make more space here to fill blood. And this pushing of the interventricular septum can at times increase pressure here. And that's going to be a question you'll get, right? What kind of maneuver would make the patient's left side have more pressure, something like that. And it would be just breathing in, because breathing in is going to bring more blood into the right heart, and then the interventricular septum is going to get pushed into the left ventricle. Right, so that's something that you see in questions. The next one is septic shock. So this is going to be someone presenting with some kind of sepsis, right, usually due to sepsis. There's distributive, neurogenic, right, so we're going to talk about all the different types. They talk about it here as well. Right, distributive shock, sepsis, anaphylaxis, CNS injury. Any of these things would cause a distributive shock. So here we're looking at septic shock, which is a type of distributive shock. It causes blood to be distributed everywhere else. So here, very interesting thing, even though this is a shock, your cardiac output will actually be higher, okay? Because you're distributing blood from the heart to all the different places. But the primary disturbance, look at where the primary disturbance is. There's two. There's this one here and this one here too. Generally speaking, the primary disturbance is vasodilation everywhere, right? Because you have an infection, you need to vasodilate to send all the blood over there, white blood cells, everything to all the different places where the infection might be and kill it. So there's vasodilation everywhere. So now using the same equation again, this one right here, if your SVR is the one that goes down, then now you have to increase your cardiac output to maintain the same MAP. So that's why here in septic shock and almost all distributive shocks, cardiac output will be high, even though it is a type of shock. Usually due to sepsis, but can also be anaphylactic. The primary disturbance is peripheral vasodilation, which will reduce SVR. So to maintain MAP, you have to raise your CO to match. On the right heart, since blood is staying in the veins, the central venous pressure will decrease, right? Because central venous pressure means how much venous pressure are you actually getting from the center, which is your heart, right? So now all the blood is staying in the veins, not backing up here, backing up into here, and backing up to your jugular veins and stuff. So central venous pressure is actually going to decrease here. The lower preload will reduce PCWP as well, because you're not going to have too much blood stuck inside the heart, so PCWP also decreases. This type of distributive shock is the only time cardiac output will be elevated. Patients will have warmer skin on physical exam because of all the vasodilation they're having. Then the other one, this one is more testable and much more likely to show up on exams, but thankfully it's not that commonly seen, right? But this is actually the one that I would imagine you should be ready for, because everything else is a little more common and more commonsensical in a sense. But neurogenic shock is something that can be testable topic simply because of how rare it is. So a neurogenic shock is the CNS injury one they're talking about here. So you see how they differentiate in step one. They told you that septic or anaphylactic would have warm skin, right? And that's why their PCWP will be low, because there's no blood in the left heart. You sent it all into the arteries. Their CVP, which isn't actually listed here in step one, but I wrote it for some of them. Right? So CVP in distributive shock would also be low because all your blood is in the veins, right, for CVP. Cardiac output would have to increase to maintain blood pressure. right? And the main issue here is this one, that you have complete dropping of your afterload, systemic venous resistance, because you're trying to keep blood throughout your body to fight the infection. So that's your septic one. Then you have the CNS injury one here, where your skin would apparently be dry, right? Your skin would be very dry, your PCWP will still be low, right? And this cardiac output will actually remain low, and your systemic venous resistance is actually still dropping because it's distributed shock. So now you can see the problem here, right? The problem here is the fact that this is different between the two, right? Remember that if your systemic venous resistance drops, your cardiac output needed to increase to maintain the same mean arterial pressure. Here, you're not doing that in the CNS injury one. So I wrote that here, neurogenic shock is due to spinal cord or brain injury leading to a lack of sympathetic output. So no matter what question you're doing, if you ever have a question where you have a lack of sympathetic output, then understand that parasympathetic output is going to overpower, right? Parasympathetic output is going to be the new ruler of the kingdom that is your body. And parasympathetic things are resting and digesting. So you're going to have unopposed vagal tone, which leads to a slowed down heart rate. And that's why this is happening, right? So any CNS injury thing generally means that you're not going to have sympathetic output, right? So you're going to have a slowed down heart rate, which can exacerbate, which can be exacerbated by hypoxic diseases like COPD and stuff. Use atropine to fix the bradycardia, and if the injury is above C3, the patient will undergo immediate respiratory arrest, which is actually a thing that came from a question, I think it was in Kaplan Q-Bank, right? So that's something to keep in mind. The C3 thing is a huge injury thing that occurs. It's very common in CK to have questions about trauma in the emergency room and stuff like that. So if the injury is above C3, right, the CNS injury is above C3, the patient will undergo immediate respiratory arrest, and if not dealt with immediately, if you don't start ventilating and start helping them breathe with a machine, they'll probably die. This time, systemic venous resistance will be reduced as well, but cardiac output will not reflexively increase, right? So this is where in neurogenic shock is different from what you see here, right? Septic shock does this. Neurogenic shock does not increase cardiac output because you can't. You have no sympathetic output. Last thing is your hypovolemic shock, which is usually a patient who lost a lot of blood due to some kind of hemorrhage or has severe dehydration or some kind of really bad burn incident occurred. The primary disturbance is the decreased blood volume. So you can see that doesn't really necessarily fit in the clinical picture of here anywhere. Any one of these things is all the way out here, right? So the problem is no blood is going to be coming back to your heart because all the blood you sent out of your heart went somewhere and then got spilled out, right? So the loop didn't finish. Any blood that leaves your left heart was supposed to come back around into your right heart, but that didn't happen. All your blood got leaked out, either through hemorrhage, dehydration, or whatever. So now, because there's no blood coming back to the right heart, obviously you can see central venous pressure is going to decrease. Since there's lesser blood overall, PCWP will decrease. If you don't have any blood, you're not going to pump anything else, so your cardiac output would decrease, which also means that your cardiac index, as you're going to see, right, will be low. So pretty much everything is going to decrease, and the only thing you can do is increase your own systemic venous resistance to try to maintain mean arterial pressure. Right, but that's not really going to help that much, but it's better than doing nothing. So that's the different types of shocks you get in questions. Very common thing, pops up a lot. It's pretty much every question you're going to get about cardiovascular stuff, and also mixed questions where you're going to have patients going through multiple different things. So make sure you're able to differentiate between those. All right, give me a second. Let me just go get some water. I'll be right back. So the various coronary syndromes, acute coronary syndromes, these are all related to patients presenting with chest pain for the most part, right? And what we, in step one, you've already seen the different types of, whether it's stable angina, unstable angina, or Prince metal angina, so you've already covered that. Now what you have to get good at is understanding what test to order once you identify the kind of angina it is, and then what to do with the patient, because those are your questions, right? It's always going to be about what should you do next, what's the best next step to take. And in our last video we covered the fact, just briefly, that this unstable angina stuff is the one that's related to people having chest pain that does not go away when they rest, right? Unstable. It doesn't matter if you're resting or not, you get this chest pain regardless at various points of the day, because you actually have a potential blockade that's going to possibly lead to an MI, right? And STEMI, non-ST elevation myocardial infarction. So for this diagnosis, you're going to have to use a bunch of things. So in CK, you're always going to be learning about all kinds of different scores and mnemonics and stuff. So there's something called the TIMI score, which is this, right? Thrombolysis in MI, TIMI risk score for unstable angina or STEMI. Again, the whole concept of using points to figure out what is the likelihood of you having to do this. Again, none of this is going to be stuff you're going to be memorizing, right? So if you're new to CK prep, this isn't stuff you have to memorize. This is more so stuff that just makes sense, because of course these are the things you're going to be looking for if you have a patient with chest pain, right? So of course things are always exacerbated if the age is over 65. This is always going to be true. If you ever read a question on CK or step 1 or any exam that's medically related, age over 65 is a whole different category. And then you start looking at the question in a different way, as opposed to reading a question about someone who might be 30, 15, or 5, right? 5 is a whole different category too. 3 or more coronary artery disease risk factors in the family. So almost every family is going to have some kind of history about chest pain. And then of course diabetes, smoking, and hypertension. The most common ones that you'll pretty much see everywhere is just going to be diabetes and hypertension. And then you have to look for one of these other issues and you're done, right? Because if you assume everyone has diabetes and hypertension, which is pretty much every question you get on STEP, then just having any one of these things leads to this also being a good check mark, right? So if they have high cholesterol, peripheral artery disease, history of an abdominal aortic aneurysm, or if they smoke, which again is another one that's pretty popular, right? Very high population of people that smoke. So that's going to be another point. Known coronary artery disease will confirm this. And then aspirin use in the past 7 days, another point. Right? If they take regular aspirin, then the TIMI risk for unstable angina goes up. Presentation-wise, if they came with severe angina, 2 or more episodes within 24 hours, that makes things worse. If they have ST deviation, whether it's elevation or not, elevation or depression, either one of those counts as a deviation. That's another point. And then if you're seeing cardiac markers, which you talked about in step 1, right? So your CKMB, your troponin, mainly troponin I, but you could see troponin C or anything. And whatever troponin you see, once you figure out someone has it, you have to go deal with it, right? So here they broke the 3 case scenarios down for you. Unstable angina, ECG, no ST elevation, you would see no cardiac biomarkers, right? It's just going to be unstable angina. And STEMI, ECG is going to have no ST elevation, but you will see cardiac biomarkers. How to differentiate between the two. So if someone is just having unstable angina, but they never had a heart attack yet, of course you're not going to see any cardiac biomarkers. Once they have had the heart attack, they had the myocardial infarction, you will start seeing cardiac biomarkers, right? And then of course ST elevation MI, you're going to have the ST elevation on the ECG as well as cardiac biomarkers. And one of the videos we did earlier, we talked about the difference between ST elevation, right, and then ST depression, right? And we talked about how depressing things are pain from the inside. So ST depression usually meant that there was damage to the heart from the inside, right? So the inner side of the myocardium was what was damaged, whereas ST elevation is a huge injury, and this was pretty much damage to the entire wall, right? Transmural infarct. So that was something we looked at earlier as well. Now this table here breaks down some things that pop up which are going to be annoying. So the most annoying thing about CK questions is that you get a question, and yes, the answer is stress test, but then which type? And then you're just like, oh, come on. And depending on what's wrong with the patient, what they're presenting with, you have to pick a very doable stress test. If the patient, for example, cannot exercise, then you can't pick an exercise issue stress test, right? Maybe they don't have legs, or maybe they're just completely unable to move for whatever reason. If they need a stress test, then you have to go with the pharmacologic version, where you can give somebody dipyrnamol and wait for the coronary steal syndrome to kick in, and then you'll see that they need basically stenting. Or you could do the dobutamine stress echo, which is probably the easiest one to do, and it's best for people who have reactive airway disease. Okay, so these are people who have like very sensitive asthma or stuff like that. And then of course both of these case scenarios, the pharmacologic, both of them, are for patients who are unable to reach THR, right? So THR. In general, which one you're going to pick is going to be pretty obvious simply based off of looking at the patient's presentation, right? You're just going to see what they presented with, and there's questions about these things throughout the book, so make sure you're doing those practice questions after our sessions or even when you're studying on your own to have a pretty good understanding of what's happening. Let me see now. So yeah, right, this is where you use it, right? Assess mortality risk, TIMI score. There's also something called the GRACE score, not that commonly used. You can definitely go ahead and look it up, but even UWorld never really mentions it. But it's something that exists, not necessarily worth knowing, but if you have time for it and you already know about the TIMI score, you can definitely go ahead and check it out. And then what do you have to do with someone who presents with this unstable angina, right? What do you do with this patient who's presenting with chest pain that is new onset, accelerating, and occurs at rest, right? Occurs at rest, doesn't go away with rest. Well, after you assess their mortality risk, you start heparin right away. Thrombolytics are only recommended if the percutaneous coronary intervention is not available within 2 hours. And this is pretty much everyone in every question, right? PCI being available within 2 hours is very difficult, especially within the hospital setting. Like a patient comes in, you're not going to have cardiologists on board all the time, readily available to jump in and do a PCI. Right, so it's very unlikely that this is what you're going to go with. So you go ahead with thrombolytics. Patients with chest pain refractory to medical therapy and a TIMI score of more than 3 or 3 or more, as well as troponin elevation or ST changes, should be given GP2B3A inhibitors like abciximab, tirofiban, and eptifibatide. These are all medications that were discussed in step 1. So again, if you've forgotten any of these medications from back in step 1, this is when you do the thing about, keeping both books open at the same time, and you go back to your step 1 first aid, look at these medications, check out some of their basic side effects and stuff like that, just in case you have to answer a question about it. It's unlikely, it's less likely. It is possible, but it's less likely in CK that you're going to get technical questions about these medications, but it can happen. So it's something you needed to know for step 1, so just go ahead and solidify that. This is why it's great that if any of you just finished step 1, perfect time to jump right into CK, because that way you still have that recall of everything you were studying, the technical stuff from step 1. And then, of course, schedule them for an angiography and revascularization within 72 hours. You have to get them stented as fast as possible, right? Before things get worse and before they possibly get a second MI or something like that, and then they can just die. Then the rest of these are more technical things, right? So these are decisions you'll have to make based off of what's wrong with the patient and how bad things are. Like dual antiplatelet therapy with aspirin and prasugrel or ticagrelor, any one of these things, should be considered for up to 12 months after angioplasty and stenting to prevent restenosis of stenting, right? But this is something you basically have to do for almost every patient, because even after a stent, rarely do people actually modify any of these risk factors. This is why this is the last thing, right? Address modifiable risk factors. No one is going to quit smoking. It's very, very rare. Even after their MI, they might try, they might work towards it, and then they go back into smoking again. No one is going to really try to, cut back on salty foods, cut back on high lipid foods, or control their diabetes better. It's very unlikely. In fact, one mentality a lot of people tend to have is after having the MI, they think nothing can get worse, and they just keep going. Right? And depending on their age, they might really think that there's no point in holding anything back. They're so close to dying, they feel like they might as well enjoy what they can. And these are all pretty pathological forms of thinking, because if they could live another 3 years, then why die now? So obviously they're not really thinking about the long run, they're just being greedy at that point. This is why pretty much everyone will get dual antiplatelet therapy after the stenting is done. Okay? And ensure that the patient is on long-term beta blockers. Right? So if ACE inhibitors, ARBs, and a statin. These are the basic technical medications everyone had to take, even in step 1. Right? You give them a beta blocker, you give them ACE inhibitors for their blood pressure, you give them a statin for their cholesterol, and then you tell them to change things about how they are every day, which won't happen. All right, so you just pray that the medications do the job. Next thing here is the ST segment elevation MI. So this one most people know pretty well. We'll come back to it real quick. Before we look at that, I wanted to look at, let me see where it was. Unstable. Did we do, oh right, okay, so we talked about stable angina stuff. Right, that was yesterday. Yeah, we talked about this already, right? So we did stable angina and principal angina, and those were just chest pain, right? So keep in mind that stable angina, right, someone who has chest pain that goes away when they rest is not an MI, right? So you don't really confirm MI until you do the diagnosis, and for your orders, like every question you get where they're going to be like, what's the best next step? For someone who's popping up with stable chest pain that goes away when they rest, the best initial test for any chest pain, always remember this, someone comes in with chest pain, no matter what kind of chest pain, stable, unstable, transmittal, whatever, chest pain is chest pain, you just go ahead and order an ECG. This way you can kind of sort of rule out that they had an MI. And then if you look for cardiac enzymes later, when you do their blood work, it should be normal in this case scenario of stable angina because they don't have an MI. Right? This is just something that's happening that might lead to an MI, but it hasn't completely occurred yet. Right? If it has occurred, then they might have actual cardiac enzymes present, right? But it should be normal for the most part, right? And you can do a stress test and so on. So keep in mind that, you know, this here they say it's substernal chest pain secondary to MI, which is oxygen supply and demand mismatch, mostly caused by atheroma. But this MI isn't a full-blown MI where they're kind of be like not doing well, right? And then they need to be hospitalized and stuff. No, this is just someone who probably just needs to have their angiography done and then cleaning up of their blockade, right? Get rid of whatever the blockade is. If they have chronic stable angina, you just put them on the same kinds of medications. Again, same stuff we were looking at earlier. Right? And they initiate risk factor reduction, which again no one does. And hormone replacement therapy for postmenopausal women is not protective of this. Right? That's another thing they love asking you about in random questions. They'll just toss that at you. So be careful of that part. So ST elevation MI. So ST segment elevation MI. So this image here is kind of showing you some of what you'd be seeing. And we've seen some ST elevation already. Right, so you have during ST elevation, which is image 2 over here, you would administer thrombolytics, which will then lead to a 50% reduction in your ST elevation. And then the T wave inversion will occur. So you can see how there's T wave inversion here. It's more prominent here. And then even after making the ST come back to normal from 4 to 5, your T wave inversion stays there. Right? The T wave inversion will deepen, indicating good reperfusion. So you kind of need that there. The deep Q waves indicate myocardial death and will remain. Right? So you see every single thing is very evident here. This first guy is normal. Everything's fine here. You don't see anything weird. And then as soon as the person has a problem, they had this first issue here, ST elevation. So this is when you see the patient and you give them thrombolytics. Alright, then look at what happened from number 2 to 3. Your Q wave got deeper. You see how it was right here? And it kind of sank to almost the second, the line at the bottom line. It went down this much. Right, so it sank, deeper Q wave. And that deeper Q wave never went away. Okay, so that never goes away because, of course, you had myocardial death. And those dead cardiac cells are not going to come back. Okay, so these are some things you can look for. And that's a silly question you can get. That, well, when will the deep Q wave recover? Never. What does it indicate? Myocardial death. And that's it. So they write here, treatment for MI, patient is moaning big from MI. So moan, right? Morphine, oxygen, aspirin, and any additional second antiplatelet for the NSTEMI stuff, like we saw earlier, dual antiplatelet therapy. Nitrates and beta blockers. So generally speaking, these are all pretty much things you've already mastered from step 1. Nothing new again, right? Remember that giving beta blockers and nitrates together is actually very effective, and they pretty much work together to make things better. Let me see. So here, ST segment elevations and cardiac enzyme release, secondary to prolonged cardiac ischemia. Right, so this is a full-blown ST segment elevation MI, which means that this is an elevation, a big problem. So it's a transmural infarct. STEMI is a common medical emergency, and prompt treatment is absolutely necessary. So of course they show up with all this chest pain, right, commonly described as a pressure or tightness or heaviness that can radiate to the left arm, shoulders, neck, or jaw. May present without chest pain, right? So you could have this silent as well. Associated symptoms with diaphoresis, shortness of breath, so they're going to be very sweaty and almost full-blown sympathetic mode. Right? They could even be vomiting because of how they feel, a lot of nausea. Epigastric pain, very common in females, and syncope. And with female patients getting an STEMI, they love putting the epigastric pain in there to kind of confuse you with thinking into pancreatitis. May reveal arrhythmias, hypotension if it's a cardiogenic shock, a new S4 because of decreased cardiac, stretchiness. I'm forgetting the actual word, but yeah, the compliance, there you go, decreased compliance, pansystolic murmur, and evidence of a new congestive heart failure. Clear lung fields are seen in right ventricular MI. So this is going to be very nice because if you have a patient who's very clearly getting an MI, right, and then they give you a chest x-ray and you see clear lung fields, then you know that it's not a left ventricular thing, but a right ventricular thing, right? Because if it's a left ventricular MI and you do a chest x-ray, you're not going to see clear lung fields. In fact, you're going to see fluid backing up from the left atrium back into the lungs, and there's going to be problems, right? So if you see clear lung fields, that means that the right ventricle must have problems and is unable to actually send things even into the lungs. So that nothing happens to the lung there, right? So right ventricular MI, which is an inferior MI, which is related to leads 2, 3, and AVF, and that is significant for SA or AV node, depending on what kind of dominance they have in their heart circulation, SA or AV node dysfunction. Right? So this is a whole different set of treatment you would have to do for them in terms of intervention. The best predictor of survival is the ejection fraction. Right? How much ejection did they lose? How much of their stroke volume isn't working? Let me see now. For all the differential diagnoses, none of these are really going to be that significant. In the beginning it was, when you're brand new to step 1, it was. Now, if you've done step 1 already, when you get a patient with this kind of presentation, you pretty much know that it's some kind of MI, right? Whether it's ST elevation or not, that's something you'll figure out from the rest of the question. But it's very rare to confuse an ST elevation MI with any of these things. Very rare. Right? Even this, like each one of these has their own presentation that's very unique. Like some with an aortic dissection, you're going to see referral pain, right? They're going to say that their back hurts too and stuff like that. They're going to be very, very hypotensive, right? So aortic dissection is more so related to someone who has hypertension that led to a rip and then they became hypotensive. So very important to watch out for that. That's going to be the key issue in these people is just going to be hypertension to begin with that probably wasn't really managed well. Right? But it's hard to confuse STEMI with esophageal reflux or a pulmonary embolism. These are all going to have question scenarios that are going to be very unique. There's this, you have to figure out how to find out what is the specific thing they mentioned that lets you know it's not an MI, but it must be some other thing that they're talking about. You got the same diagram again, all the same troponins and whatnot from step 1. Now I put this table here from CK breaking down a little more about each of the medications. But again, if you've forgotten any of this from cardiovascular farm back in step 1, go back to first aid step 1 and make sure you revise that. There's not much else they really talk about here. They start going into ECGs, and as usual, we already know how to evaluate all our ECGs like a boss. You get an ECG, break it down in half, and you start looking for your R-wave progression. And in fact, you know that this was supposed to point down and this is supposed to point down. But right here, you already start seeing some sort of a problem. You get this weird curve that's happening here. You don't really expect that. That's not supposed to happen. Other than that, pretty much, you could see there is an R-wave progression, right? It does end up eventually pointing up, and it's highest here and here, so that's pretty good. Then you look over here for 2, 3, and AVF, and you kind of figure out your answer, because as soon as you try to see where the ST is, you can see that the ST is not coming back to baseline. Right? So ST is not coming back to baseline, where your P started. So there is ST elevation there. There's a very significant ST elevation here. Right? It's much higher than what you look for in both 3 and AVF. And then the last thing you would always check for is axis deviation, which you look at 1, 2, and AVF for that. They should all be pointing up, and they are. So there's no axis deviation. So this is just going to be a person who has an inferior MI, because the actual issue is these guys. That's it, 2, 3, and AVF. So that's an inferior MI. Something's wrong with the diaphragmatic surface, right? And this is really problematic because, as we know, those are the places where you have your arteries that could supply the SA and AV node. Right, so you're going to need to be able to read the ECG and master that pretty quickly to evaluate that pretty quickly to be able to answer a question within a certain time frame. Here, this one is very evidently extremely different from this one, so you can immediately see there's something funky going on here. So same thing again, you just go ahead and evaluate it. You know this is pointing down, this is pointing down, that's good. As far as R-wave progression is concerned, although there is some level of an R-wave progression, something really weird is happening in these places, right? So those are considered your leads V1, V2, and V3. Those are considered the ones that are in the front, like this, right? Because remember the way they're placed on the chest, V1 goes over here on the right side of your mediastinum. Your mediastinum is right here in a sense, right? It's much bigger than that, but I'm just drawing it like that. And then V2, V3 are all the things. All these other guys are on the left side. So there's something very evidently wrong with those. Then you look at the rest, like 2, 3, and AVF. Well, 2, 3, and AVF look fine. They don't look as beautiful as always, and this is definitely a little smaller than you would want it to, but I don't see ST elevation in them. Right? I don't even see ST depression in them, and you know the distances between R's are 3 boxes each time, so that's all good. Everything's fine. Axis deviation also fine, right? 1, 2, and AVF are all pointing up. Okay, so the axis deviation is normal. There's no axis deviation. So then the only issue this person could possibly be having must be related to leads V2 and V3, and it's probably some MI, right? Because of the way it changed. The way it changed has got this like weird elevation here, right? Remember that this is supposed to be this QRS complex is pointing down, right? It's still pointing down here, so this is backwards. But then as soon as you come to here, this should now be pointing up. And it should stay pointing up over and over and keep pointing up. And I think in the one place it's most evident that you see an ST elevation is actually V5 in this case. Right? If you look at V5, it's very nice that you have a clear baseline to some extent because the ending here, so if I pull it like that, right, you can see how there's an ST elevation. It didn't come back down all the way. Right? So the normal would have been to come back all the way and then have whatever T or something. So yeah, as soon as you start seeing that, you start thinking anterior wall MI, which is this yellow area, right? And then based off of the colors, remember they were all related to different blood supplies, and you would pick the blood supply for that question. So if someone comes in with any of that, again, the management stuff never changed. So these were things that were talked about in step 1. Unfortunately, this is probably the stuff you mastered the best from step 1. So you know it, and you pick the correct answer here too. You know, and then you just move on. Nothing new here for management purposes. Giving nitrates, giving pain relief, giving antiplatelet therapy to prevent any kind of stroke from happening. You know, you don't want blood to clump up, right? You don't want blood to clump up anywhere and then lead to a stroke because of the MI. So you give a lot of antiplatelet therapy as necessary. Consider beta blockers, but always be careful when giving beta blockers to people, right? Make sure you're picking a beta blocker that's cardio selective, like carvedilol. You don't want to pick something that ends up also messing up their respiratory function, right? Because beta-2 receptors are on their lungs as well, and if they have COPD or asthma, you can't give such a beta blocker to those people. You also can't give beta blockers to anyone whose heart rate might be around 60, because beta blockers decrease heart rate, and if you bring the heart rate below 60, that's going to make them bradycardic. So very, very important to be careful when you prescribe a beta blocker in questions and in practice. And then if the patient is in heart failure or in cardiogenic shock, do not give beta blockers, right? If they're still in heart failure or cardiogenic shock, because beta blockers are after, right? Here they said consider beta blockers as the hemodynamics allow it. So once they're better, once everything's okay, then you can give it. But if you give it while they're still in heart failure, while they're still in cardiogenic shock, then you're gonna essentially mess up what their body is naturally trying to do to recover. Right, last time when we talked about all the things related to cardiogenic heart failure, right, we talked about all these different things that occur to vasoconstrict, right? You're going to stop all of that if you give a beta blocker when they're still trying to do this compensatory stuff to maintain their own blood pressure. Beta receptors are on the kidney, beta receptors are on your heart. You're not going to be allowing them to do any of these things. Right, beta blockers are given for blood pressure because it actually can impede the renin-angiotensin system from working. So if you give it to a person who still have congestive heart failure, you're going to stop them from doing this. And then beta blockers, especially beta 1 blockers, will stop them from doing this. So you don't want to give somebody a beta blocker if they're still trying to do this cardiac remodeling. You're going to mess up their natural response to their suffering. And then, let me see now. This is another thing that keeps popping up in questions. It's something that gets students. In an inferior wall MI, which is basically a right ventricular infarction, you want to avoid nitrates and diuretics due to risk of severe hypotension. Right? Remember that if you have an inferior MI, your right ventricle is the one that's not working, as you can see here. Right? The blue area is covering all of your right ventricular stuff. Now, right ventricular stuff is for blood coming back into the right heart. That's mainly what it does. And if you give nitrates, nitrates increase preload. Nitrates cause more blood to come back to the heart, and that's really going to mess them up, right? Any other MI, nitrates are okay. And generally speaking, for chest pain, nitrates are okay. But not for an inferior wall MI, which is very common, very testable, high iotopic, relating to 2, 3, and AVF, right? You do not give these people a nitrate. Don't do it. So you're going to see that as an answer choice. Sometimes what happens in such questions is that you see multiple answers that make sense. Or 2 to 3 answer choices that all look like things you would give to a person who had a heart attack. So then start thinking of why you would pick one over the other. So you might have a beta blocker, a nitrate, and an antiplatelet. Think about it. Giving an antiplatelet to anyone is generally okay. There's no problem, right? Any one of us in this room right now can take aspirin and we'll be fine. It's not something that's really problematic or dangerous, etc. The only people that should never take antiplatelet therapy is when you really, really need your platelets, and that's probably not what your question is about. But giving a beta blocker, even though that might be one of your answer choices, could be the wrong answer choice, because it could be somebody who might still have bad hemodynamics, right? Maybe they're still so they tell you what the bad hemodynamics are. You can't give it to someone who's still trying to recover their left ventricular function, right? So the list of things right here. And then the other wrong answer choice that might look right is a nitrate, but then you realize it's a right ventricular failure. You shouldn't give a nitrate either, so then you pick the antiplatelet. Right? So picking an antiplatelet as an answer choice is the safest answer for someone who's post-MI, because that's pretty much the first line of treatment and the most important thing and safest thing to give. Also, you get weird questions that are pretty much a piss off about what are things that decrease mortality in acute coronary syndrome, and aspirin is one of them. But there's more than just aspirin, and they don't go into too much depth here. Let me see, I think they have a list somewhere. None of that. Not that either. Where do they put it? No. Oh yeah. See, and here's a list of people who you can't give antiplatelet to, right? Can't give thrombolytics to. So if you have that as a list of answer choices as well for the same question I was saying, that you might see 4 to 5 things in your answer choices that all look like things that go to a person who had a heart attack. Make sure you can see why you would not give someone that. So again, this makes thrombolytics a difficult answer choice to pick, but you can always pick antiplatelet therapy safely. It's almost never something that you have to avoid in a person. They had a list of things that actually reduce, I'm sure it's somewhere, but I have it in the step 1 book, so we can go look at it there. But a list of things that actually reduce mortality, right? So you need to know all the things you can give to a person that are actually significant and must be given to a person to reduce the chances of them dying, right? So here, this is where they talk about ACS treatment, right? Unstable angina or NSTEMI, you go ahead with anticoagulation, antiplatelet therapy, add another one like your ADP receptor inhibitors. This is also for antiplatelet therapy. Give a beta blocker, give an ACE inhibitor, add statins, and then symptom control with nitroglycerin and morphine. These are all the things for unstable angina. You have to know this concoction. For someone who had an ST elevation MI, in addition to doing all of that, reperfusion therapy is the most important, PCI. And these are the basic things we talked about. Where's the stuff about what's actually going to reduce mortality? I know I had it somewhere here. Alright, well, if I find it, I'll talk about it. But there is a list of medication types of things that you're supposed to give to patients who had an MI or have heart failure in general to improve their mortality, right? So that they don't die. And those things get tested. They'll ask you a question, and then they'll put multiple things there, and then they'll be like, which one of these medications is the best thing to give to reduce mortality? And they might all be great medications for the person, but only one of them from that list of answer choices is going to be something that reduces mortality. So I don't know where that list is right now. If I see it, I'll save it for our next session. But here's one. So this is one that you definitely need to know. Aspirin reduces mortality in ACS. But there's a couple other things that reduce mortality in other conditions as well, and they're worth knowing, so I'll make sure I mention them. I'll find it and I'll talk about it in the next session. They go on then to tell you, okay, you get your initial treatment, but that's not it. The patient can't just go home after that, right? They just had an ST elevation MI. So now you have to do the interventions, and this is where it gets a little more complicated. So you have emergent angiography and PCI should be performed if possible, right? Superior to thrombolysis. This is better than doing any of this thrombolytic therapy. However, doing emergent angiography and PCI isn't always possible because you don't always have people available. And your question is, this person could be anywhere where there might not be sufficient help. They create all kinds of scenarios. If PCI cannot be performed within 2 hours, then door to balloon time should ideally be less than 90 minutes, right? So again, this basically means, this door to balloon time thing means that you basically need to do the PCI as soon as possible, right? So if you cannot do the PCI and there are no contraindications to thrombolysis, which is all listed here, and the patient presents within 3 hours of chest pain onset, then thrombolysis with TPA, retiplase, or streptokinase should be performed instead of doing the PCI because you couldn't do the PCI. There was no time or not enough faculty available, or whatever the reason might be. Thrombolysis target time, which is your door to needle time, that's what they call this, is less than 30 minutes and is contraindicated if more than 24 hours. So again, now you're seeing how things are getting a little complicated. This is almost like diagnosing the differences between schizophrenia and the schizoaffective disorder and stuff, right? Because it's all based off of time difference and nothing much more than that, really. So thrombolytics can be used up to 12 hours from the onset of symptoms, but mortality benefit extends to 12 hours only. After that, it's really not that that useful. Long-term management for all patients includes the aspirin, ACE inhibitors, beta blockers, nitrates, and high-dose statins. Very important to give all of these guys. Can't pick one off, you have to give them all. If PCI was performed because somehow you actually got the patient in within the first 2 hours, then you also add clopidogrel and prasugrel or ticagrelor for the dual antiplatelet therapy, just like we talked about earlier. And of course, tell them to live a better life if they're going to listen. Then you have the notorious topic of everything that happens post-MI. Right? So step 1 loved that topic. Right? And there were so many questions about this page. Everything that happens, evolution of an MI. Right? Within the first 24 hours where you just had your heart attack. First 3 days, 3 to 14 days, 2 weeks after, right, to basically even a year after. Knowing these things is very significant, very, very important, and it should be pretty logical. So you can see here they did a very good job just basically summarizing it. They didn't go too in-depth. They just literally summarized it. That's it. And they kept it very simple. And unfortunately for your test, it's not going to be this simple. But it's a nice summary, though. It's definitely a nice summary. So first day you could have heart failure because you just had your MI. Right? Then you could have arrhythmias or pericarditis. After that, 5 to 10 days, you could have left ventricular wall rupture. And then weeks to months later, you could have an entire ventricular aneurysm. So now let's actually delve into the details to make sure we have this down pretty well. So in the beginning, right after having an MI, for the first 0 to 4 hours, nothing will happen. Literally nothing changes. This table over here does a really good job kind of showing you that. Right? Minimal change. Then in the first 4 to 12 hours, they wrote here early coagulation necrosis, edema, hemorrhage, and wavy fibers. You're going to see these really interesting wavy looking fibers. Early coagulated necrosis, release of necrotic cell contents into the blood, because remember, a lot of cells died here, right? So if those cells died, they had to release their contents. There's going to be edema, hemorrhage, wavy fibers. Neutrophils are going to start coming to clean up things. You could get reperfusion injury, which is associated with generation of free radicals, leading to hypercontraction of myofibrils through the high free calcium influx. So now, what is all of this about? Why is this happening? So it all comes down to understanding the release of things from those dead cells. What actually came out of those dead cells? So when any cell dies, their sodium potassium ATPase no longer works, right? So this portion here is basically what explains all of that. And this segment right here is actually what helps you answer this question, because this question on the right side was very I think this was one of those questions where it was like a 40% got it right and the rest all got it wrong and picked other answer choices, one of those kinds of things, because of the way they worded the answer choices. Okay, so always remember, when a cell dies, the sodium potassium ATPase doesn't work because there's no ATP. So without ATPase, that sodium potassium pump doesn't work, so you end up accumulating extracellular potassium. Remember, the function of your sodium potassium pump, Kn, right, like that. So you can always remember pumpkin as the mnemonic to tell you that sodium potassium ATPase's job is to pump potassium into the cell. So now you're going to have a lot of potassium out here, floating out here, okay, outside the heart, basically. In addition, intracellular accumulation of sodium and calcium pull in water, right? Because when you pump K in, you also pump sodium out. And then remember that the heart and many other cells also had your sodium-calcium exchanger. So all of that is not going to be working anymore. So your sodium and calcium ends up remaining inside the heart. And sodium is basically salt, and salt pulls water, so all the water goes into the heart, right? So then now you get this really weird heart that's very full of water and has a lot of potassium outside. Remember, hyperkalemia was something that gives you risk of arrhythmias, and that's what I wrote right here, right? Can cause arrhythmias. All that extra potassium you have outside increases the risk of them having an arrhythmia right after having an MI. So you see your list of complications. You could have arrhythmia, you could have heart failure right after the MI, of course, and you will have cardiogenic shock right after the MI because you're unable to have a good stroke volume in this moment. Right? So none of this should be intensely complicated. The first day, you're just going to have heart failure and cardiogenic shock. Those two are obvious. And now you know you're going to have ventricular arrhythmia because not only do you have a lot of potassium outside, but you're also equipped with the calcium inside to help do the contraction. Right? High free calcium influx. So everything is there for the contractions to occur and lead to an arrhythmia. Now let's say they make it through this. Great doctors, all taken care of. They make it through that. They make it to day 1. Right? So 1 day finished. Now they're in between days 1 to 3. So let's say they're in day 2 now. Now they're going to have extensive coagulative necrosis because that's what happens in the heart. Right? Tissue surrounding infarct shows acute inflammation with neutrophils. So here now, because you have all this neutrophilic activity and inflammation, the only thing that can happen in this middle phase is post-infarction fibrinous pericarditis. Right? Pericarditis makes it hard for the heart to actually expand well. You're going to hear a pericardial friction rub. Right? You're going to have an ECG with diffuse ST elevation. Even though there are no more MI anymore, you won't know any more CKMB or troponins. And you'll know that it's day 1 or 3 or whatever based off of when they were admitted. It's all just going to show up as pericardial effusion. They have pericarditis, right? So you don't really have much you can do at this point. You wait for them to recover, all right? So that's basically what you're looking for there. So this phase is the easiest one. Again, in my opinion, once you actually learn it, they're all pretty easy to remember as long as you can remember the correct order in which these things are happening. Let me see. Hello? Yeah, I was teaching right now. Did you need something? No, it's okay. All right, bye. Let me just see what's up. Okay. So this, like, for example, when we talked about the first 24 hours, this was pretty obvious now. Right? All the potassium outside with the arrhythmia, the heart isn't working that well, so heart failure and shock. Perfect. After everything is cleaning up, all you have is a lot of inflammation, so pericarditis. That's all that can happen there. Now you come to the later days, so 3 to 14 days. So basically in the first week, right? So think of like day 5, day 7, day 10, stuff like that. So around these days, there's a breakdown too, right? First day, it breaks it down pretty vaguely. There's a more specific breakdown. So you can see days 1 to 5, 5 to 10, and 10 to 14, right? 3 different days that can, or 3 different groups that you can break the 3 to 14 up into, right? So right after you recovered from your heart failure, you recovered from the inflammation and the pericarditis, the only thing that's really still happening in the first 5 days is the coagulation necrosis and the continued neutrophilic infiltrate. Then eventually macrophages are going to finally reach to get rid of more debris, right? They're going to clean up everything, and you're going to have granulation tissue left. That's the final product for now, and neovascularization in a sense of recovery. However, there is a problem with this, right? The granulation tissue. Now remember, granulation tissue is collagen type 3. It's a type 3 collagen that later on, after the 2 weeks, metalloproteases are going to come and convert this collagen type 3 to collagen type 1, making it nice and solid, which is very unfortunate because your heart is not supposed to be nice and solid, right? But right here, though, this granulation tissue, this yellow part that just recovered, isn't all that strong, okay? Now, of course, your patient should theoretically be taking a lot of medications to keep everything good, and they should be staying well. But if they don't, right, because after, the hardest part of treating MI is everything after, right? This part was the easy part. The patient came in, you dealt with it, you treated them, you took care of whatever, then you released them. Now they're released. Now they can go out and do anything, and it's that post-MI part that's really hard. So what can happen here is something might go wrong, and they might have exerted too much force, and they can actually get a free wall rupture. Right, so this segment right here, that's brand new, can just end up plopping out, as you see here. Okay, so it's a pseudoaneurysm. It's a pseudoaneurysm because this plop that you see is a pseudoaneurysm simply because only the yellow lining that you're seeing of the heart, only that popped out, not the entire red muscle too. Okay, so that's different from as opposed to like here. Right, the whole thing popped out. Okay, so if just the wall outside popped out, that's your left ventricular pseudoaneurysm, which can occur just because they put too much, they exerted too much force, maybe to pick something up or walk somewhere weird. I don't know what they're doing, and boom, that pops out. Or they could have an actual free wall rupture, which is the wall rupturing inside. That's what that's about. And so either way, no matter what rupture they get, something can break, and that's all you need to understand, right? That at this point, after, remember up to here, they were still recovery. Now they're kind of done with the recovery phase. Now they need to maintain, but this can break because this is brand new. This is brand new stuff. So things can break. They can end up developing mitral regurgitation because of papillary muscle rupture. They can get tamponade because fluid is going to leak out and then surround everything outside. You can get a big bag of fluid outside. And the pseudoaneurysm. Any of these things can only occur pretty much up to here. The posterior medial papillary muscle rupture is the most common simply because that one has only one blood supply as opposed to the other lateral papillary muscles. And then if they still made it through here and everything went well, right? So they did the they recovered, and then they maintained this, and they got to here. Well, this just sucks in its own way, right? Because now you have this solid portion of your heart that's not supposed to be solid. It's a contracted scar that's going to be now collagen type 1, and it's going to be too hard. It's not going to beat as well as it was supposed to. So these patients now eventually will, of course, have an S4, a late diastolic heart sound, which occurs because when they're almost done with diastole, which is what late diastole means, they filled so much blood in here that it kind of makes a sound with this non-contractile, non-compliant left ventricle. It's not stretching. So it's hard for them to fill it. So then again, because it's hard for them to fill the left ventricle, they can get heart failure. Right? Because this doesn't contract that well, they can get arrhythmias. And since this entire thing is just a big wall that can, fail at doing its job, the whole thing can break. The whole thing. So that's why it's a true ventricular aneurysm. The whole thing can break. Here, only a simple outer layer that was just developing will break, and you get a fake aneurysm. But now at this point, the whole thing can just break. That's unfortunate. Your heart could also decide, your body can also decide that this gray portion doesn't look normal to you, and then your body decides to kill it. That's your Dressel syndrome, right? Where macrophages and antigen-presenting cells can present cardiac antigens to MSC2, which will then go ahead and kill your own heart because you don't think this is yours. And of course, you can't really blame your immune cells to see this gray portion of your heart and be like, that doesn't look normal, and then they want to attack it, right? So that's pretty common as well. And the other thing here is this mural thrombus thing, right? So just because this is a solid wall, your heart can now basically start painting on it, and that's what you're seeing here. Right? So you have this solid wall here that's labeled number 3. You have this solid wall over here where blood can just start accumulating, and if this person gets a ventricular arrhythmia, all that accumulated blood is gonna break off and then go into the aorta and possibly cause a stroke. Right? So there's a lot of complications, and the point is to stop all of this from possibly ever occurring by giving all of that excessive antiplatelet therapy, excessive beta blockers, and all of these other things, so that none of this happens, because at the end, all of these things are things that can eventually lead to death, and you want to prevent that. Right? So having an MI is really quite the unfortunate issue. So spend some good time making sure you really delve into the specific treatments of these things. Now, what I did was, when I was studying these things, and then of course, remember at the end of this, I have this checklist of things here. So you could definitely go ahead and use this as well, and just make sure you know the exact way to diagnose, what would you order, and exact way to treat each one of them, right? So that's your coronary artery disease stuff. This is your acute coronary syndrome stuff. Right? All the things you need to do. And when you look at these summary things, just make sure as you're reading these summaries that there's nothing here that's confusing, or nothing here that you don't know how to explain to someone. Because if there is something here, then you want to go back and look at it, either back in the step 1 book or continuing to look it up maybe on Google or something, anywhere. And then you're, of course, definitely going to see these things in questions. Thankfully, these cardiovascular questions are not the most difficult things, and they're pretty easy to do. All right, in the next video, we're just going to wrap up the rest of this, because these are not that difficult. So dyslipidemia, hypertension, pericardial disease, and then the vascular diseases. This will be the next big topic, so I'm going to rush through the dyslipidemia, hypertension, pericardial disease, and then spend time on vascular disease so we can wrap up cardiovascular. And then before I have you guys go, I just want to let you all know, and I'll put this in the recording too, so I haven't stopped the recording, that the dermatology chapter is not one I'll be covering, right? So there's not much to talk about here, so I'm just going to let this be. This chapter is all stuff, again, that is literally from step 1. There's nothing new here. There is, I believe there are only 1 or 2 new things here, like the decubitus ulcers. I'll talk about that one. And I'm going to look through it just to see if there's anything else I do want to mention and discuss. But other than that, most of this is all just self-memorization, self-understanding, not really that physiological, right? There's no crazy physiology here. These are all different kinds of pathologies that have their own pathophysiology, how they occur. So that is all mainly stuff you study on your own. So we'll be skipping that and jumping into endocrine, hopefully by Friday. Also, I wanted to show you guys this thing. So this is your NBME exam 7 for the clinical science self-assessment, CCS exam, right? So I did the same thing for this too as I had done previously for the step 1 NBMEs. I wrote out explanations and breakdowns for each one of these questions, because these are pretty much what you take to see if you're ready for CK or not, in a way. Again, NBME exams are pretty trash for the most part anyway, so it is what it is, but this is what we have to our disposal. So I went ahead and made these explanations for everyone, and these will be stuff that I'll be giving out to people. I'm doing the NBME 6 as well. I'm finishing it up. I'm done with this one. I'm half done with the number 6 CCS exam. So once these are done, these are going to be the stuff that I'm going to give out to everyone who stays for February as well, so that we can start looking at some of these together and break down how to tackle them. Alright, so thanks a lot for joining, guys, and then enjoy the rest of your evening.